Bear with me. There we go. Hopefully you're all happy with this recording. We generally upload this to our YouTube channel, which is only accessible to those that join these meetings. So it's a professional space, but no patient names, if that's okay, just to maintain confidentiality. If you have any questions, you can pop it in the chat and we'll put that to the team at the end of the session. Okay, thank you very much. I'm going to hand over now to our children and young people's team. We have Jennifer Brownbridge and Kira Norwood with us, who are both working within the Children and Young People's Task Force. So really excited to hear all about the work that you're doing to improve the lives of our children with asthma in the region. So welcome both of you, and I'll hand the floor over to yourselves. Feel free to share your slides.
Thank you. Just bear with me. I'll just get myself set up. So I'm hoping you can all see that, but I can't see.
I can see, Jen.
Brilliant. I just can't see anybody. 1 minute. Sorry, I will start in a minute. Right. So yes, thank you for having us today. My name is Jen Brownbridge, and I'm new in post as one of the Asthma Task Force for young children and young people for the Humber and North Yorkshire ICS. I've just got some slides. They're not too long, and I won't linger on them, and then we'll just have some questions and answers. So we've got Kira with us today as well, and I think Sarah Jane Foxton has joined us. Kira, would you mind introducing yourself, and then Sarah Jane, and then I'll crack on.
Hi, yeah, I'm Kira Norwood. I'm going to be, I've come into post a couple of weeks ago into this new asthma task force. So we're part of a pilot from NHS England. It's really exciting to deliver asthma care across all the services across North Yorkshire and Humber, really, and just trying to improve things and sort of add a bit of support and some pathways.
Hi, I'm Sarah Jane Foxton. I'm a paediatric consultant at Harrogate Hospital, which is a DGH, and I lead for the respiratory there. And also I think Marcia has joined us as well. Jen, you may or may not be able to see.
Thank you. Marcia, then, if you wouldn't mind introducing.
Hi everybody, I'm Marcia Pathak. I'm a GP from North East Lincolnshire, and I'm also one of the clinical leads for this work, which we're all really enjoying and really passionate about.
Fantastic to have you all. Thanks for all joining.
Thank you. So yeah, so I thought I'd first start with a little bit of an explanation about where the program's come from. So it's part of the CYP transformation program, and the improvements in care for asthma were sort of highlighted within the NHS long-term plan. So
we can't see the slideshow, Jen. I don't know if you want your slideshow up or not. I don't.
Is it not up? Oh no, sorry. Can you see them now if I just flick through like that? No, oh my goodness. Sorry guys.
Maybe go again, Jen, just go through the sharing process again.
Does it just knock me off?
I think so. Good old IT.
Good old IT, yeah.
It was there, Jen, at the start. That's it.
Can you see it now?
Yeah, perfect.
Brilliant. I'll start again. Sorry about that. So yeah, so it was highlighted in the NHS long-term plan that we needed improvements in asthma for children and young people. So we've got the national CYP transformation team, and then there's been appointments of regional leads, and we have our regional lead, who's not on the call today, but I'll introduce her name and job role in a moment. And then obviously that with that came some allocated funding for asthma clinical leadership. So that's where the likes of Sarah Jane's role and Marcy's role in terms of that clinical leadership. And then mine and Kira's role have come from a national pilot that we were successful in bidding for Humber and North Yorkshire. And that's again around rolling out the national standards for the National Bundle of Care for Children and Young People with Asthma. So this bundle came about from the national team because obviously, as I'm sure you're all aware, given that you're all working within asthma and respiratory, it's one of the most common long-term conditions in children in the UK. And unfortunately, we do have the highest rates of emergency admissions and deaths in Europe, and then outcomes are worse in the most deprived areas. And obviously, we've had various reports highlighting the factors that have led to them issues in the care for asthma for children and young people. So obviously the NRAD report. And the ambition is to reduce avoidable harm by adopting a system-wide approach to address all factors that exacerbate asthma, poor asthma care. So things like environmental triggers, looking at education of the workforce, looking at preventable medicine and improving diagnosis. So in effect, that's the asthma bundle. So our team, so the head of our team currently is Karen McNicholas. So she's our Children and Young People's Programme Manager for the ICS. And we have Karen Nickerson, who's our Project Support Officer, who comes to our meetings and is sort of helping to direct us when we need to do projects and things like that. She's been a fantastic support to us. And then we've got Marcia, who's introduced herself, and then not on the call today is Dr. Rebecca Brown. So she's a primary care clinical lead for the team, and she's based in York. And then Sarah Jane, myself and Kira. And then we've also got our newly appointed Children and Young People Asthma Nurse Coordinators. And we've got 3 of those, and they're working in 3 different areas as place partnerships. So we've got Jenny Wood, who's working for Hull and East Riding of Yorkshire. And we've got Ruth Fowler, who's working in North East Lincolnshire and Northern Lincolnshire, and Rachel Sinclair, who's working for York and North Yorkshire. And I'm not sure, I'll share these slides, and there is a link here, which you may or may not have seen if it was circulated last week. It's a link to sort of an introduction to the Asthma Task Force and a bit about our work. So if you want to have a read, and if there's anyone that you think that you might like to pass that on to, we'd be very grateful. So if you don't already know, I will explain it very briefly about the components of the national bundle. But basically, the national team developed the bundle, and it was published last year in September. And so with the idea of sort of looking at the areas of greatest impact to improve asthma care. So we've got environmental impact, so that's looking at air quality, it's looking at smoking, it's looking at housing and things like that. And there's also a little bit about air quality around schools. Then early and accurate diagnosis, so looking at links and pathways between primary care, secondary care and tertiary care, and looking at how we can sort of standardise them pathways and make sure that they're equitable across all of our patient populations. Effective preventative medicine, so sort of working with public health, looking at self-management, personalised asthma action plans, things like that. And then management of exacerbation, so looking at how things are managed in hospital, bundles, sort of discharge bundles when they're discharged from hospital, so thinking about 48-hour post-attack reviews. And then as a region, we don't actually have a severe asthma service. We feed into Sheffield and Hull for paediatrics, but looking at the severe asthma services, and there's talk of having like a dashboard of all them patients that are under the severe asthma service and how we manage them effectively. And then underpinning all of this underneath, there is the training competencies, and then there's a national database now to pull together the data, which helps us look at which areas within our region maybe have the highest levels of admissions for asthma in under 19s. And looking at where we can target the support. So for our team, that means that obviously it's quite a big area to cover. So it's looking at which areas we can target by following that data. we have started to do some of that work. So I mentioned the asthma pilot, which is mine and Kira's role. So this was about providing targeted interventions to patients in primary care with the highest children and young people's asthma admissions, and to prevent avoidable asthma attacks and escalations in care. So the 2 paediatric asthma practitioners were given to 1 ICS in each of the regions. So we bid against the other ICSs within the North Eastern Yorkshire region. We were successful, and me and Kira came into post about 3 weeks ago now, so we're into 3rd week, so we are very new in post, and we're already starting to think about what we can do in our role. But the national team want us to establish pathways across the ICS, so that's why we've hopefully come today to gain some good links with primary care, and share knowledge and learning, and best practice. Identify where we need to identify where the asthma outcomes are poorest, and establish the reasons for this, and see whether we can help to improve care for children and young people with asthma in them areas. We have a specific remit about looking at diagnostic pathways, and looking at the development of diagnostic centres, and there's also leading on identification of those children and young people at the highest risk of exacerbations and managing their care appropriately. So we're looking at risk stratification tools currently, and how we might utilise these to pick out those high-risk patients. And then to supplement that role, we've obviously got the asthma nurse coordinators, which is Jenny, Ruth and Rachel. So they're all working on a 12-month fixed term contract or secondment, 30 hours a week, and they've been tasked with engaging with primary and secondary care, and doing a bit of scoping and understanding the challenges that are faced in providing good care. And their work is very much being guided by that data that we're gathering from the dashboard. So looking at a targeted approach. So for instance, PCNs with the highest levels of unscheduled care. So some of you may or may not have met Jenny, Ruth or Rachel already in your areas, but we'd be really grateful for any support and links you can provide us, so that their work and their time is useful and utilised to the full advantage in the next 12 months that they're in post. So I've just put a little bit about what the vision of the task force is, and generally for children and young people as a whole, is that we ensure that they have the best start to life regardless of their health needs and where they live and their background. And the ultimate aim is to have a fully connected system that provides the right care at the right time and place. We want to engage with all of our system partners across education, social care, voluntary sectors and housing, for example. In terms of education, we're looking at asthma-friendly schools, so improving the care of children and young people with asthma in schools, and the sort of education for staff working with those children to sort of highlight them kids that are maybe having high levels of absences from school. And we're also trying to look at housing and about what processes are in place if housing is highlighted as an issue for those children and people with their asthma, and about how we escalate that through systems in local authority to maybe get rehoused, children rehomed, and we don't really understand them processes very well at the moment. So our initial project plan is to sort of start building them relationships, and we're also, and I can talk a bit more about this if it's of any use, but we're looking at commencing a telephone triage for the 48-hour post attacks for asthma. We're looking at doing that in one place area first and then rolling it out across the ICS, with the view that we know that 48-hour post attack reviews don't generally happen, and we want to try and add some support to the system really by doing that, and that the triage system would highlight those children that really do need that face-to-face review early to avoid them having a readmission to hospital. And as I mentioned, we're looking at the Asthma Friendly Schools initiative. We're going to start looking at in a little bit more depth at the pathways and the consistency of these across the network, and then obviously the development of the diagnostic hubs and this risk stratification tool. And then just how you guys can help us would be just to link us up with the relevant professionals working with asthma with children and young people, and help us. We would welcome any ideas and thoughts on how we can move this project forward and guide where we best focus our attention. I'm going to stop sharing now because I've waffled on long enough, but any questions, and Kira, Sarah Jane or Marcia might want to add something as well, so I'll just stop sharing.
Hi, can I ask something if that's possible?
Yeah,
I know that you said that about the problems with housing and things, but within my practice, I work across 4 sites at the moment, and a lot of our patients are very socially deprived, and particularly in the last year, I've noticed, and I suppose the recent death of the young child really did bring it home to me. And I actually only mentioned last week in one of our meetings that previously, if a patient has needed any communication from us regarding a child or an adult's asthma, and the need for damp to be addressed within people's homes, we actually charge for a letter for the council. And given that people are really struggling financially at the moment, I find it quite unacceptable, to be honest, that we're doing that. And I know last week it was agreed that for certain patients that charge would be waived, but even with those letters and even with the photographic evidence, Hull City Council are terrible at addressing the problem of damp in these homes. And I know that we talk about health inequalities within the Hull area, but I think that if there's a way that we can better engage with Hull City Council and the East Riding as well to try to really address this, because it's unacceptable that people with severe respiratory symptoms are having to live in these conditions. And I think back to a child I saw earlier this year, and he's sleeping in a bedroom that the ceiling is black, and he's having to sleep with a window open. He's got significant allergic rhinitis that's triggering his asthma. And I find it so infuriating and so maddening that despite that evidence, that family is still living in that home. And then we wonder why there's health inequalities. Well, we have poor outcomes in our area because things like that aren't being addressed.
Yeah, and I think when we what I probably didn't stress the point enough on the slides is we are looking at health inequalities as one of our main focuses in deprivation. We are tasked with, so one of the deliverables in the asthma bundle is about lobbying housing, where it's been highlighted as a factor in asthma care. But we know that that's generally probably happening, certainly with patients where it's significantly an issue. But often with the feedback I've heard, certainly anecdotally, is that these letters often go in and it doesn't really make a difference. The national team have developed a letter template, which I can share, which is really good, but it needs some personalisation about, and like you say, photographic evidence and stuff like that. But I think ultimately there's a lot more work to be done that probably is outside of our jurisdiction, really, I suppose. Kira.
Yeah, I think what we're looking at is really kind of looking at getting a pathway in place, though. So what we're kind of trying to do, but we are finding it quite difficult. And I think we're hoping that there is some, this tragic death really helps us to kind of get in there, with these housing associations and local authorities. But as a network, we're just trying to create a pathway for professionals so that people, like you say, they do know who they're writing to, and they know that will be read and they'll have some impact. And I think that's what's kind of come from that young boy's death, really, is that there just needs to be clear pathways in place. So we're kind of hoping that, in terms of that, we'll be able to kind of work with housing associations to identify people that we would be able to link in with, and then we'd be able to share that with as a pathway for professionals. But yeah, it is a big piece of work, and I think a lot of it we can't, like Jen says, we can influence, but we can't change, unfortunately.
I think the other thing to say there, Kira, is the development of the ICSs may help us here, because we are starting to see some closer working between health and local authorities. And I think obviously you've had some frustrating responses from Hull City Council, but I will say that in terms of our asthma network, Hull are probably one of the most engaged local authorities out of all of them. They are starting to come to the asthma network meetings. We've had meetings with their air quality, the people who monitor their air quality outside schools. We've got a meeting in place with housing from Hull. So they're the only local authority from our whole ICS that have actually agreed to meet us and start to discuss what their processes are. So, I mean, it's baby steps, isn't it? And I work in a very deprived area of Grimsby as well. And I absolutely understand your frustrations. And I think you've raised the wider issue of deprivation and our diverse ICS. And, you know, we're not going to be able to go into each, you know, we're not going to be able to say, here is a solution for primary care for children's asthma, because we've got such a diverse group of practices, diverse group of communities. So what we're planning to do is try and take a much more kind of bespoke approach. And that's why we've got the asthma nurse coordinators in each area to really try and drill down with practices. You know, what are your issues within this practice? Why are you struggling to get patients in for reviews? What are the barriers to you delivering good asthma care? Because, you know, it's easy to say, oh, well, this practice isn't performing, but actually, you know, it may be that practice is a really deprived area. You know, there may be cultural issues within the community that means that people aren't engaging. You know, so I think all of these are things that we're really keen to get going with and sort of make some progress with, but I share your frustrations.
It is frustrating. I do wonder if practices should be actually charging for these letters as well. I don't know whether there's a way that the ICB could maybe look at encouraging practices to waive these charges for things like this across the board, because it just doesn't seem right that, because many of our families, they cannot afford the cost of these letters, and so they're never gonna, they're not even going to get as far as lobbying the council to try and improve the damp if they can't afford that. If they're struggling to put food on the table and they're queuing at food banks, they're not going to be able to afford the £25–30 letter to try and improve their living conditions.
Absolutely agree, yeah.
Lisa, that might be something that we could discuss at the Champions meeting next week, actually. So if you bring that to the table, John Hancock will be there, who has obviously got some influence within the respiratory network and can feed it into theirs within the respiratory network. It might be something that we can then talk to and bring it to a practice level. I'm sure it will be a PCN type decision. But yeah, I think raising that, and if it maybe means tested or something like that, it might be something to look at. So yeah, really, really great point.
We can raise it as well.
Yeah, absolutely. Absolutely. I think it'd be great if we all start kind of raising it and stamping our feet a little bit. It's all good, isn't it, if we start spreading the word of the issues and the barriers. And Marcy, you just mentioned about kind of overcoming barriers. So I thought I'd maybe just put it out to the group. We've got quite a few respiratory champions, so lots of people that are interested in respiratory and caring for respiratory in primary care. So I just wondered if anyone would be happy to talk about any barriers that this team could maybe help you with, because I'm sure that I'd help you in terms of your development, your rollout of, particularly with the asthma coordinators and what they're doing and going out and doing. Is there anyone who's got any barriers or anything that the team might be able to help with?
I can say something if you want, but I don't want to talk.
I saw Lisa maybe thinking as well.
You know, similar to, you know, if you get, say, a baby that's going to be coming through that's Hep B positive, and you get a list of any patients that might need that immunisation or that heel prick testing at 12 months. Would there be a way that the asthma coordinators could get a list at each, you know, of any, some communication between HUF and those primary care asthma nurses to be able to ensure that the practices are informed when anybody is discharged following a paediatric asthma discharge, you know, so that they are followed up in a timely manner.
That should be happening already, really. And one of the things we're focusing on is the 48-hour review issue. And I know particularly within primary care, there's been a lot of feedback that there's a concern around capacity for doing a 48-hour review on every patient that's admitted with an exacerbation of asthma. I've started to do them at our practice, and actually we found that for our sort of very deprived population of about 6,500 patients, we probably have a couple of calls a day to do, 2 to 3 calls a day. And to be honest, it's quite unusual that we maybe would have to bring one of those in the same day. So it's not led to a massive workload for us, but actually what it has done is really improved relationships with those families, and the families have felt really well supported. And we managed to engage with a lot of hard to reach families by doing those reviews. So I think Jen and Rebecca, who's one of the other GPs, are doing this trial on the sort of Yorkshire end around the telephone triage, and they've developed a triage tool which is based on a tool from another area, isn't it? But you've added some bits, Jen, to try and sort of risk stratify those patients. Of course, what there are also is a lot of admin processes, isn't there, around admissions. So, you know, there's the letter's got to come out rapidly from the hospital. Also, we need our staff within practices, our staff who pick up the emails within practices, our admin staff, to be able to recognise that this is a letter about a wheezy child and this needs to be escalated to the asthma nurse immediately, rather than going into a list of letters that the GP might look at, you know, over the next couple of days. So there's admin processes as well that will need to support that. I mean, in terms of risk stratification generally, what we're really excited about, as the first ICS in the country who's actually recruited to our band 7 and 8 roles, we are now a pilot area, and Jen will be able to talk a bit more about this, for a risk stratification tool, which is being rolled out, which looks at things like days lost from school, admissions to hospital attendances, too much SABA prescribing, not enough preventer prescribing, you know, all those kinds of issues, DNAs, and it puts it all into a big machine and risk stratifies these children, and we'll be able to identify the highest risk children in our kind of communities for us to identify them. So that's, Jen, could you speak a bit more about that, because you know more about that?
Yeah, I mean, it's early days with that, but this is something that the national team are wanting to use as a tool, and look at how we can use that risk stratification to stream them patients that are at the highest risk from their asthma and get them seen by the most appropriate professional. And the reason we sort of looked at the 48-hour reviews as a trial is because actually those patients that have had an exacerbation of asthma, have been admitted to hospital, they automatically really are in that medium high, sort of even to very high risk of subsequent asthma attacks. And so actually that 48-hour review becomes really an important step in trying to avoid that readmission. So and the tool, it brings together lots and lots of different elements, you know, things like, have they had an asthma review, how many days lost from school, although we're not sure how they're going to incorporate that just yet, housing, smoking exposure and stuff like that, and then it gives them sort of a score that would mean that they would be medium high and very high risk, and then we would hopefully then that would mean that they'd be highlighted as somebody who needs a review. So that is ongoing, and obviously watch this space with that, and we can probably come and talk a bit more and a bit more eloquently about that when we've got a bit more information, but it's a really exciting development. But the 48-hour review part is what we're looking at, is that, Lisa, so the issue that you're mentioning about that communication, that has been our biggest barrier in terms of setting this up, and we haven't even started the pilot yet, is how our coordinators will get them patients and a list of them patients to then make that 48-hour review. So actually, if a child, quite often, routinely at this time of year, a patient will be discharged from hospital having had whatever they've been admitted for without a discharge letter, because actually there's not capacity to sit and write a discharge letter. So often they'll say, oh, we'll send it on in the post. But with asthma and with wheeze, that could then mean that that 48-hour review is missed, and that primary care are not made aware of that admission for maybe at least, you know, up to a week, and realistically potentially even longer. So you've missed that opportunity for the 48-hour review. So what we're looking at is whether our asthma nurse coordinators can get a list every day of the patients that have been discharged from ED and then discharged from the wards. They would use this tool, again, a similar sort of risk stratification type thing of the amber patients, the red patients and the green patients, so red, amber, green. If they're in the red, that tool would stream them into going back to hospital or urgent care because actually they're worsened since discharge. The green patients would have, you could delay seeing them face to face, but you would make sure on that triage tool that they'd had good education on leaving hospital, inhaler technique check, they've got a personalised plan, and they've got a follow-up arranged in for sort of 4 weeks time in secondary care or primary care. But them amber patients are the ones that actually do need that face-to-face 48-hour review.
My treat. I've got some sauce and stuff if you want to come in. I ain't got my camera on. The mayo, KFC mayo if you want some.
Hi, sorry.
Kirsty, could you just mute for us?
Oh, sorry.
Hi, it's Lisa, Newman Pierce, working home. I think some of the barriers for children is that a lot of our training is based around adults when we first do the adults, and so sometimes, even though I do asthma and things, I get a bit thinking with children, get a bit worried, and what the main concern I have is that the GPs often won't diagnose, they'll send them to us, and yet, the other regime is where the doctors maybe had one chest infection and they'll have given them Clenil or they'll have given them salbutamol when there's not been diagnosed asthma. I just think there's loads of issues around the GPs and actually diagnosing asthma correctly for children. I don't like to see under 5s because that's the protocol, but I have referred people before, but then I've had a thingy back from the hospital saying, because they'd already been put on Clenil by the doctor, that then they won't see them, but then it puts us in a awkward position with the GPs. Sorry.
No, it is really tricky with the under 5s, but also, like you say, if you sort of that diagnosis of suspected or has asthma but has not really actually had diagnostic tests or a proper assessment and actually started on Clenil with very little sort of good quality history taking.
And sometimes you're only going by parents, and I'm not saying that they're wrong, but I find it really difficult when I've got a child in that I'm trying to ascertain whether they've got asthma, because like I did do, the pheno machine came the other day and I did do one on a child and that came back fine, but he's running around like a loony, no signs of breathlessness, no wheezing or anything, but obviously the mum says he gets a cough on a night, which could be linked in with the asthma, but I just worry that even though we're practice nurses, we are actually supposed to make the full diagnosis. I think we use the pheno and thingy, but this child was too young, it was under 8 to do a spirometry. So I mean, I've given him pig flares to do at home and stuff for a couple of weeks and then to come back, but I just feel sometimes I feel the pressure that I'm a practice nurse, not a prescriber or a diagnoser, but obviously with asthma and COPD I've got knowledge in, so I do my best, but I feel that the GPs really just let us down by
I think you're right. I think anything that nurses get very good at leads to a bit of de-skilling of GPs within practice. I'm the same with diabetes. I'm hopeless in terms of diabetes compared to my diabetic nurse who's done all these other courses. And so I think you will find an element of that where you've got specialist nurses within practices who, you know, or even nurses who are doing the majority of the work, you can get an element of sort of de-skilling, can't you, of the doctors if they're seeing less of those patients sort of routinely. And then they're perhaps asked to see a patient as an emergency because, you know, you wouldn't have an appointment, and then suddenly they're expected to know, you know, to be very familiar with the kind of management and things. I think the training will help. So there's national training that's been released now, and we would expect all our kind of practice nurses and our GPs to have done up to level 2 training, which is available on the e-learning for health, the tier 2 training. They could do level 3 as well, I think, if they wanted to, couldn't they, Jen? But certainly we want them all to be trained to level 2. So that will help in terms of kind of updating. And I think then I think it's down to very much individual practice, isn't there, about how their teams work together. you know, what opportunities there are for sort of shared discussions, MDTs, you know, and sort of how individual practices work. And I think I'm hoping that when the coordinators go into the practices and work with quite a few different practices and see the different ways that practices are working and delivering asthma care, that we'll perhaps be able to share some really good examples of what other practices are doing, you know, to practice teams, because often it's just things that haven't occurred to you. You know, I'm a firm believer as well, you know, in primary care, of that actually, you know, anything that sort of an administrative person could do shouldn't be being done by clinical staff. So, you know, so sort of taking over those kind of admin type roles associated often with management, and, you know, so hopefully we'll be able to find lots of really good examples of that to help practice teams have better ways of working together. And then hopefully nurses will feel more supported. Yeah.
Hopefully you can see.
Oh, sorry, I was going to say, just to add to that, it was as part of streamlining pathways between primary and secondary care, and secondary then and tertiary care, we're hoping to try and set up some kind of NDT, almost like working groups, Lisa, so that you're not left floundering, wondering what to do. And we find it tricky in secondary care, kind of diagnosing even what wheeze is. Sometimes the family, you've no idea, they're talking about wheeze and we're talking about a completely different noise, aren't we? So it's tricky at all levels. But I think if we can start building up that relationships between with the coordinators in place, we can then provide some support that between secondary and tertiary care, they're just starting now having groups where you can bring difficult cases and talk, and I think it's been really helpful, so we can see how we can mirror that back down. We're all in the initial planning stages, so the kind of challenges are really helpful to hear, so then we can start working together to put the solutions in. Does that help?
Yeah.
That's great, thank you. And actually, with a lot of the people that are on the line, actually with the Respiratory Champion groups, we're looking to develop a similar kind of thing in adults, in terms of that we've got an MDT and somewhere to take these complex cases or difficult cases, so we can upskill those that are working it out in primary care. So I think that would be absolutely fantastic. And the training at Bundle again sounds like a really fantastic opportunity.
Let me just quickly go over the training aspect of it. So there is the tiered training 1 to 5, and it's available on the Learning for Health, is it, website? So it's all there together. It's free. So up to 1, 2, and 3 is free of charge. There is a cost for tier 4. It's £480, I think, plus that. But that would be more looking at people who are very specialist or diagnosing. For 3 would be looking actually, and 3 is still suitable for general practitioners, specialist nurses and specialist practice nurses within PCNs as well. 3 is really in depth, so that might be an option for people who are looking at sort of developing that knowledge. And then sort of the level 2 is quite quick, it's 45 minutes, and it's a really good overview. So, you know, they're the kind of options really in terms of that. If you've got anybody that you're working with that are also working with children, so thinking of like stuff like social prescribers, but potentially we know there's some social prescribers out there now for CYP, that might be suitable for the tier 1 as well. So anybody who's working with children can do tier 1, and that gives them a really good overview of asthma in general with a non-clinical focus. So 2 is your clinical focus, and 3 is just a little bit more in depth to think about, you know, if you're working directly really with in asthma in a specialist role. And yeah, tier 4 is the one you have to pay for, but that is very in depth, and that is like a portfolio based kind of way of doing things. And 5 is more for the people who work in the tertiary centres, so that wouldn't be applicable here, I don't think.
Where will other teams hear about this? The training is, are your asthma coordinators going to go out to practices and or reach out to PCN leads to try and encourage staff to get on this? Because I do worry sometimes that training sits there and then isn't, either time isn't given or the practice nurses aren't made aware that it's available.
So when our nurse coordinators and myself and Kira, when we go out, we've developed a very brief sort of checklist, is probably not the right word, but like a checklist of things that we want to know from each PCN area or practice about how they manage asthma in children and young people. And one of the questions is about training. And I think we would be hoping initially as a soft approach of just highlighting that training's there. But I think we did talk earlier in one of our other planning meetings about whether we do some in communication, sending it out sort of to the net through via the ICS and via PCNs, and just to highlight that this training is available, and that actually the National Asthma Bundle does state that if you're looking after children and young people with asthma, that you should have the correct level of training and expertise in managing them. So that's an overview of the training. I've put a link in the chat to the sort of capability framework document, and most of it is available through, I mean, if you go for e-learning for health and put asthma training for children and young people, it's the tiers are set out. So tier 1 obviously is for, like Kira says, for sort of non-health professionals, and then tier 2 to 4 you would have to find the one that was suitable to your role, and see whether you can do that. And they're quite good training packages. They're all online, they're quite accessible, you can do them at your own pace and stuff like that. And obviously as a team we'd be happy if you've got any questions or you feel that there's any gaps that you need filling, then you can give us a shout and we'll try and help the best we can and feed it back to the national team that have developed the training package. But yeah, I think initially we want to sort of let everyone know about it as many ways as we can, and then we probably do need to look at something more formalised about sort of some communications about it, because it is a little bit hit and miss whether people know about it.
Yeah. Is there also mentorship opportunities? So like Lisa mentioned about some of the difficulties she's experiencing in asthma diagnosis, is there a mentorship role of the teams that are being rolled out into kind of our local areas to sit within clinics and support upskilling of staff?
I mean, I would certainly see that as being part of the role of the sort of band 6 nurses. I mean, obviously, they've not got endless capacity, but certainly if there was somebody within a practice who felt that their practice needed some support in delivering care, that's exactly the sort of communication that we would want. We want those coordinators to be used in the practices with the highest need, really. And certainly we'll try and seek those practices out in terms of the data. But if a practice actually approached us and said, we need support with this, I think, that would be support that we would want to offer, wouldn't it? I think, does the rest of the team agree? So as I say, if the team were to be emailed, to email one of us, then we would be able to let the relevant asthma nurse coordinator know, and she can make contact with those practices, because they're planning to try and get into all practices ultimately. So
fantastic, really awesome. Great. Have we got any other questions from anybody else on the line?
Can I just add a quick thing around transition, because I think that's something that potentially with this group would work really well. I have a 16-year-old son who's a really sensible son, but my God, his asthma control really is deteriorating greatly since I have been unable to order his prescriptions for him, for instance. And and I think it's the average ACO-pick sort of 16-year-old boy, which I used to despair of as a GP, but now my own son's that age, you think, pull yourself together, but they just don't organise themselves, do they? So for me, I'd be interested to know what people's perspectives are on control, sort of in that sort of 16 to 18 group. Because I've realised his space is all crusted up. And he wasn't using it properly. And then these are, we're sort of being encouraged to consider dry powder inhalers now, aren't we? Sort of in the teens for that sort of reason. But I'd be interested to know what people's perspectives are, whether it's just my son that's particularly bad, or whether this is a bit of an issue that we've got once you take away that parental support to an extent, or parental control over when they're using their inhalers, etc.
I think it's a really important point, actually, and I think something that we're probably not brilliant at, even in secondary care. So I worked in secondary care for many years. We did transition clinics, but again, probably wasn't brilliant. I don't think the relationship between kind of the paediatrics and adult services was enough. So certainly in primary care, I don't think it's broached enough or considered enough, really. I actually had an experience which I'll just share with the group about kind of the importance of this. Is we had a young girl who transitioned out of paediatrics. She was actually on biologics, so she was on injectable therapy for severe asthma. And within a year of transitioning over, she'd become non-concordant with her therapies. Unbeknown to us, in all honesty, she kind of told us everything we wanted to hear. She had a young child at this point. She was 16, nearly 17. then stopped turning up to her appointments for her omalizumab, and then was actually found dead in her bed, grasping onto her blue inhaler, stockpiles of inhalers. There was obviously an inquest and lots of different things looking into that, but for me, that struck me so significantly. I was part of the team that she didn't come to appointments for. We did all we could in terms of contact. But I think it's a really difficult thing coming from paediatrics into adult. It feels very scary. Do we prepare them enough? Often children who have got bad asthma growing up, parents, mum, dads can mollycoddle them a little bit and do a lot of the stuff for them, so they don't necessarily have all that education in place ready to move forward. So yeah, I'd love to hear other people's opinions, but I think it's definitely something we need to improve on. And as I move into the lead of the severe asthma service, it'd be great to kind of team up and look at how we can better improve that transition as well. So I'd love to speak to you more about that.
Yeah, in my experience in my previous role before this at York, the transition pathway is almost not there, because there isn't actually a service to transfer them into for them sort of. It's the severe asthmas, there's services to transfer them in, but often we're just transferring care back to the GP. And it is an issue, and we've had a recent event about transition in children and young people, sort of in that that we should be starting it as early as sort of 14 and actually signposting it even earlier, actually, that, you know, and trying to improve that education and independence from an early age, so that it's not a massive shock when they get to an age where suddenly mum and dad can't order prescriptions. And Kira better answer this better, but because we've been looking at the data, and there is a significant increase in hospital admissions after that transition period into adulthood, in that sort of 18 to 24 bracket.
Yeah, it's very significant actually. So what we see a large rise in attendances sort of between 5 and 10. So that kind of where children need diagnosis age, where perhaps they're not this recurrent viral wheezer, actually they are an asthmatic and they need an ICS and they need a management plan. And then we see actually sort of early teens, things sort of settle down. We don't see much kind of attendances in hospital. And then we see a massive spike in attendances. Last year, actually, there was a massive spike in attendances in sort of the 20 to 24 age range in hospitals. It was larger than any other age ranges of paediatrics in terms of, and that's quite surprising because that's a well population, isn't it? 20 to 24 is a population that doesn't really feature very much across the board. And what we're sort of thinking is probably aspects of transition around that. There's aspects of, you know, when these young people have reviews and they're sort of 16, 17, are they being asked, are they planning to move away next year? Are they planning to register? And I think that's something we really want to build into those annual reviews, is about, you know, that kind of, it's springing to mind at 16, 17 to ask about that transition, because it's likely that they're moving away and they're not registering and they're not being able to get any inhalers, for instance. Or they're not going to reviews and then they're not able to access treatments because they've not attended a review. So it's just those sort of questions, and also just lifestyle changes. So if they're going on nights out, are they taking the SABAs with them? You know, are they able to do that? Have we got an appropriate SABA for that? So it's a lot of, you know, questions for young people. And I think when we talk about children and young people, we focus very much on children, but we really don't want to miss out on these young people because they just don't feature. But they do feature in the stats. So they're you know, A&E is absolutely so busy, and the adult A&E side is busy. We don't want these guys going into adult A&E if possible. So yeah, it's really an aspect of the work, really.
And I guess things like this start to experiment as well, don't they, and come out of the clutches of parents. So things like smoking cessation, vaping, all of those kind of things start to creeping. And again, I think that's another thing that we aren't brilliant at in asthma. We talk about it a lot in things like COPD, don't we? But do we broach these kind of things in asthma, and particularly in primary care? I wonder what the practice nurses think, but do you always talk about smoking cessation, vaping, other things that they might be doing that might be setting these things off? Triggers.
We have been working with the smoking tobacco dependency programme for the ICS as well, about developing some leaflets and some signposting leaflets as well for clinicians working with them, with anyone really who's smoking is a factor. so there is a lot of good work going on there with that, and they're putting the Quit Together program together with there's a website that I think it might already be launched, but it's not fully populated yet, but that should signpost everyone to the right services in the right area, and they very much promote the very brief advice training for professionals. And again, that's another thing that we probably need to do a piece of work on, about making sure that people looking after children and young people have that training.
The other bit, the other bit around that, and I just think this is so key, is around there's now a lead midwife for smoking in pregnancy, and actually now that they don't just offer smoking cessation to the lady who's pregnant, but they offer it to everybody in the household who smokes, be that partner, kids, brothers, sisters, mums, dads, whoever it is. And they do continue to support after the pregnancy for a bit. And they're actually starting to, there was an article in the BMJ around financial rewards for quitting smoking I think it was a month or so ago. And they are actually starting to look at that in our region, like whether they could actually provide financial incentives for staying off the cigarettes after pregnancy and not sort of running straight outside and lighting up as soon as they, and obviously that will make a massive difference to our households where we've got, you know, young children who've either already got asthma or who will develop asthma if that smoking continues. So.
Absolutely. I think, was there another question? Lisa, do you want to just ask about, you mentioned about an expectation for child asthma nurses to see and assess patients in clinic. Do you just want to expand on that, Lisa Galloway?
Yeah, just trying to understand the role really, to be honest, if that's okay, Helen, just a little bit better. So, because I know that I think they're looking at policies and things like that, but I just wondered if there was any expectation to actually be seeing patients and assessing them in clinic as well.
Ruth Fowler, who's our nurse for Northern Lincolnshire, she's been out to our practice, and what she did was she observed our asthma nurse doing some clinics. Now, certainly we have said that we would be happy for them to demonstrate sort of how to deliver the asthma reviews if that's what a nurse needed, and certainly to observe clinics, to offer advice, support. Yes, it will be very much kind of practical on the ground. And I say each practice, it will very much depend on what that practice needs. So some practice it might be administrative procedures, audits, etc. around asthma, just to improve processes for follow-ups and annual reviews and things like that. With other practices, it might be, the nurse doesn't feel hugely confident in delivering the reviews, so they might need that kind of on the ground support, maybe to do a few clinics together. It may be that actually they want a bit of on the ground teaching for the practice team. So really the roles are still evolving, but there'll be all of that. Yeah, all of that will be included depending on what each individual practice needs.
Great, thanks, Marcia.
Fantastic. We've got just a couple of minutes left. Is there any other questions to the team? I mean, I'm so glad we had the whole hour, because it's been great, great to have these conversations and having this narrative. And it'd be great to have you guys back again in the future as the roles develop and your work develops, to see how this is moving forward and how it can be integrated into our practice and how we can support that delivery as well. So any other questions? Silence.
Well, thank you so much for having us though and listening to us, and if any information or any links that you can make with us, we'd be really grateful. We are very new in what we're doing and we're sort of finding our way as we go, so we've certainly not got all the answers, but we just need sort of some good links and sort of some good working together.
And our asthma coordinators are really keen to get into practices. So if there are any practices that really feel that they want some support now, or really feel that they want to be, one of the first practices to have our asthma nurse coordinators come in and spend some time, then by all means contact one of the team, and we'll flag your practices' names up and pass them on to our.
Fantastic. If your local coordinator or any of you want to come, we've got a Respiratory Champions meeting next Wednesday evenings. It'd be a really good opportunity to meet a representative from each PCN across the Humber region. So more than welcome to do that, but I can also pass out email contacts for the teams to get in touch. So hopefully we'll get you supported by the PCNs across the board. But thank you so much. I think actually this is something that's So needed, so needed. Children get lost a little bit in asthma. I think we talk about adults a lot. So it's really exciting work. So yeah, thanks again for joining us, and thanks to everybody for coming along. Bye everyone.